Good morning, everyone, and thank you for joining us at the second session of the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by Be Well Texas. My name is Andrea Roche. I'll be facilitating our conversation today. Thank you again so much for joining. I just have a few quick housekeeping notes before we begin. To help us with attendance, please enter your name, your affiliation, and your email into the chat function. To access that chat feature, go to the bottom of your Zoom window and click on that speech bubble icon. You'll probably see it flashing right now with everybody already entering their information. To all the Be Well Texas providers, please make sure that you identify yourselves during the session by entering your information into the chat. And if you're joining by phone only, please make sure you email that phone number and your name to bewelltx@uthscsa, that's bewelltexas@utesca.edu. We'll throw that link over in the chat in just a little bit. We are recording these sessions, as you saw, and we do make them available for later distribution through the Be Well Texas YouTube channel. Know that any information you put in the chat will not be shared on those recordings. We encourage all of you to join by video for the discussion portion of the session at the later half of it. But that said, regardless of how you join, by phone, by video, or just joining on your computer, we're happy you're here with us. Please do stay muted though, unless you are speaking, and we encourage everyone to speak. If you've joined by computer, again, that mute icon is on the lower left of your Zoom window. If you've joined by phone only, press *6 to unmute. If there's a lot of conversation, a lot of people talking at once, you can also use the reaction menu in the bottom right of your Zoom window to indicate that you have a raised hand and have a comment to share. But there are a lot of us in this space, so try to keep your comments brief to allow other people time to discuss and talk as well. And finally, most importantly, note that no protected health information is allowed in either the chat or our spoken discussions today. Towards the end of this session, keep an eye on that chat. The Be Well Texas team is going to send out a link to a post-session evaluation survey. So please fill it out. It gives us feedback on how we can shape this series to meet your priorities and your needs. And it also allows you to get free continuing education. Right now, we're approved for CEs for paramedics and any public safety professionals with a behavioral health degree like social work or a counseling credential. We are looking into other forms of CE. So if the types of CE I just listed aren't relevant, go on and fill out that post-session evaluation survey and let us know what kind of CE would be helpful for you. And also the most important bit, I save for last, anybody who fills out that survey is entered into a drawing to win a free $30 Walmart gift card. So help us out and hopefully get a gift card out of it. If you are new to this space, just a little bit about this series. Our aim here is to partner with all of you in building public safety professionals' capacity for responding to substance use and substance use disorders in their daily work. And that spans a large spectrum of work. This includes recognizing substance use, employing brief screening tools, referring or transporting to appropriate point of care, and preventing or responding to overdose. So we support each other's growth through these regular sessions that include brief learning presentations and didactics, and then cases shared from the community of learners and group discussion about those cases. Really, that's where a lot of the learning comes, is us sharing our own challenges and our own strategies to the cases presented each session. ECHOs thrive on conversations that acknowledge and include the perspectives of many. So we welcome your questions, your experiences, and your perspectives in all of our discussions. We're all learners and we're all teachers in this space. So let's get started first with some introductions of our hub team. I'll start with you first, Jeremiah.
Sorry, hello everybody. I'm Jeremiah Golca. I'm the Executive Director of the SHIELD Training Initiative. And we do safety and health training for people throughout the criminal justice space. And thanks for being here today.
Thanks for joining us. Cynthia.
Hi, my name is Cynthia Mendiola. I am a retired federal probation officer, and I work with CCF Incorporated, coaching and training probation officers nationwide in core correctional intervention strategies. Welcome.
Thank you, Cynthia. And Jesse Trevino?
Hi, Jesse Trevino, co-founder and president of Solution One Plus. I was a former San Antonio Police Department detective, and before that, mental health officer. And I worked at the Southwest Texas Fusion Center as the Mass Violence Prevention Coordinator.
Thank you for joining us. David.
Hello, I'm Dr. Dave Miramontes. I'm the medical director for the San Antonio Fire Department. I'm an associate clinical professor at UTL, and we do Suboxone where we find you in the San Antonio area.
I like that promo. Adrian.
Hi everyone, Adrienne Lindsay, Director of the Center for Substance Use Training and Telementoring here at Be Well, Texas at UT Health. Thanks for being here.
Thanks, Adrian. Andrea.
My name is Andrea Havler, and I'm here a program coordinator for ECHO and CSTAT at UT Health San Antonio. Thank you.
Thank you. And then to our didactics and case presenter today, Joseph.
Good morning. I'm Joseph Martin. I'm a physician at UT Health with the Department of Emergency Medicine, as well as the Department of Addiction Medicine under the Department of Psychiatry.
Thanks for joining us. And those of you, we've got a great number of people coming in today. So if you're just joining, make sure you use the chat to enter your name, email, and affiliation so we can capture that for our own records and to introduce yourselves to the other learners as well. So we're going to get started with those didactics. Joseph, you have screen sharing abilities. When you are ready, take it away. Looks good.
All right, perfect. So again, I'm Joseph Martin. I'm a physician. I work within the UT Health system. I'm an addiction medicine trained physician as well as an emergency medicine physician. Also occasionally work in the EMS component with Dr. Miramontes on occasion. I have no financial disclosures. I just work for UT Health. So kind of the things that we want to address today are opiate use disorder and opiate overdose, especially within the pre-hospital setting. Kind of some things that I'm hoping that we address over these next 10 to 15 minutes. By the time that I finish is that you feel comfortable explaining how and why naloxone administration is effective in acute overdose. Help to identify individuals who may be experiencing opiate overdose by the way that they present with their symptomatology. Describe administration of intranasal naloxone, as well as describe potential opportunities for addressing opiate use disorder in the setting and context of acute overdose and reversal with naloxone. So after you see these patients and they've been reversed in the field, potentially taking that opportunity as a way to convert them to a patient that is willing to be seen and evaluated by addiction medicine services for continued treatment. I'm not sure how everyone will have access to naloxone. I know there's a lot of paramedicine professionals. So this will particularly talk about intranasal administration, but we will touch on intramuscular administration as well. So kind of some basic vocabulary. It's easy to get caught up on the words. I mean, the reason we go to medical school for so long is just so we can learn another vocabulary. So I definitely want to help to make it a little less intimidating. Affinity, this is the strength with which something binds to a receptor. The higher the affinity, the stronger the chemical bond between the substrate and the receptor, the medicine and the receptor. An agonist is something that stimulates a receptor. So it may also sometimes be referred to as a receptor stimulator. An antagonist blocks a receptor, also sometimes referred to as a receptor blocker. And then there's a partial agonist. And the reason I bring that up is because it specifically is relevant to buprenorphine or Suboxone, and it helps to explain and understand why Suboxone is kind of unique and does what it does. But it partially stimulates and by rule also partially blocks a receptor. And I'll talk about that in a little bit more detail. So on the right, we see a picture of heroin. And if you may notice the name Bayer, the same Bayer that makes Bayer aspirin, was actually the first pharmaceutical company to manufacture heroin. It was in fact a pharmaceutical drug. It was actually initially marketed as a general pain reliever, but also as a cough suppressant, even a cough suppressant for children, no lie. But this was in the early 1900s before we knew any better. Naloxone, which is ubiquitous and we use it in the field very, very often, is an opiate receptor antagonist or an opiate receptor blocker with a very high affinity for the receptor. So what that means is that it not only is a blocker of the receptor or an antagonist of the receptor, but it also has a high enough affinity, a high enough chemical bond whenever it interacts with the receptor to actually kick off other medicines, other drugs. Specifically, it works by kicking off fentanyl, heroin, oxycodone, hydromorphone, morphine, opium, codeine, hydrocodone, or any other opiate that you may have in your system whenever naloxone is administered. It kicks the drug off of the receptor and is a full blocker, which is why these patients typically wake up whenever you administer naloxone to them. So buprenorphine, and I want to touch on this just because we use it so frequently and it's becoming much more commonplace in the treatment for opiate use disorder, is a partial opiate agonist and a partial opiate antagonist with very high affinity. So it can actually kick off other medicines, which is why if a patient very recently used heroin, hydrocodone, morphine, fentanyl, etc., you can actually put them into withdrawal. So the very high affinity component means that it binds to the receptor more strongly or with a greater strength than the other medicines you see listed. So it will kick off the other medicines. The partial agonist means that it will stimulate the receptor, but it only stimulates it a little bit. It doesn't stimulate it as much as fentanyl, which is a full agonist or a full stimulator, or heroin, which is a full agonist or a full stimulator. So what that means is if your opiate receptor was a volume knob, when you bind fentanyl, volume's at 100%. When you bind buprenorphine, the volume's at 50%. Which is why buprenorphine is a safer drug for medication maintenance and for medication-assisted therapy maintenance. It's also why if you give somebody buprenorphine who recently took fentanyl or heroin, you can put them into withdrawal. You take the volume from 100% to 50%. Hopefully that makes sense. So signs of opiate overdose, I want to keep it as straightforward and simple as possible. Unconsciousness, shallow, slow breathing, or complete absence of breathing or apnea, pale skin, blue lips, snoring, rasping breath. I left pinpoint pupils purposefully as the last one because it can be one, a little subjective, but two, it can fool you. There are opiates out there that do not cause pinpoint pupils. Another thing that we will touch on later is polysubstance abuse, or when folks are abusing multiple substances at once. There are substances that conversely can cause dilated pupils. So you can get kind of a mixed picture. And unfortunately, I've seen people erroneously anchor on a overdose presentation as not being opiate related because the patient simply did not have pinpoint pupils, even though they had everything else, and that was a missed opportunity for naloxone. So pinpoint pupils can be suggestive. However, it is not diagnostic if the pinpoint pupils are absent, and that's something I definitely wanted to hit on. But in overdose, as with any overdose, BLS principles really are paramount. CPR saves lives, CPR saves lives, CPR saves lives. The BLS principles of assessing scene safety, making sure the scene is not a potential danger to the rescuer, shake, shout, and stimulate, trying to wake the patient up, trying to get their attention and see if they respond. Assessing for breathing if they have either apnea, absence of breathing, or bradypnea, slow breathing, assessing for that. Calling 911 and getting them involved as soon as possible so that they can respond to the scene, administering naloxone if available, and then if all else fails, call 911 and CPR. But again, blue lips and pale skin can also be seen in cardiac arrest. So don't get hung up if you see blue lips and pale skin that they're experiencing an overdose. It could be a cardiac arrest. Naloxone is very, very safe to administer in cardiac arrest. So if that's the case and you administer it, you're not going to cause any problems. Just don't forget naloxone, then CPR if you don't have a response.
Naloxone is now available in most places without a prescription. Naloxone is a temporary antidote for opioid drugs, which include, but are not limited to, heroin, fentanyl, morphine, codeine, oxycodone, and hydromorphone. You should give naloxone if you suspect someone has overdosed on an opioid. Suspect an overdose when someone isn't responsive and they have at least one of the following signs: not breathing, slow and soft breathing, making snoring or gurgling sounds. Their body is limp, cold and clammy skin, bluish lips and nails, pinpoint pupils. If you think that someone has overdosed, stay calm and call 911. Each dose of naloxone can only stop the overdose for about 30 minutes. To give naloxone using a needle, uncap the vial, insert the needle, and slowly draw the naloxone into the syringe. Inject the naloxone into a muscle in the person's arm or leg. It isn't necessary to remove their pants or shirt. To administer naloxone nasal spray, place the tip in either nostril and press firmly up on the plunger. If the person is breathing, put them on their side to protect them from suffocating or choking. If they aren't breathing, perform rescue breathing if you know how, until the paramedic arrives. And finally, while waiting for the ambulance, remember, stay on the line with 911. Don't try to get the person up because they could fall. Don't put them in a bathtub or shower because they could slip, drown, or go into shock. And don't give stimulants like crystal meth or caffeine because it can make them sicker.
I found that video to be quite entertaining at the end with not administering crystal meth, though ironically, it does happen. Once this patient has been assessed and naloxone has been administered and hopefully reversed, there are some opportunities, depending upon the kind of patient that you encounter, to potentially get them plugged into treatment services. Naloxone is pretty quick. It's not always instantaneous, so it may take a minute or two. During that time, don't forget to assess and see if they're breathing. If they're not breathing, start CPR. But assuming that they've been successfully reversed as directly as possible while maintaining compassion, because these are definitely high stressed and emotional situations. So it's best, if possible, to try and remain as calm as possible. Explain to the patient what happened. Explain to them that they either were approaching cardiac arrest or that they were in cardiac arrest or about to be from what looks like a overdose, whether accidental or intentional. Explain to them that they need further evaluation and transport to the hospital for continued care. A lot of these patients will be hostile. A lot of them will refuse. A lot of them will try to exit the scene that they're at very quickly. If that's the case, especially if they're hostile, don't try to force them unless that's within your discipline, within your training. Be very, very careful with these patients. They tend to be very kind of confused, waking them from their overdose state. But if they are willing to be transported and willing to discuss, ask them gently if they were trying to overdose on purpose. This is helpful for a multitude of reasons, as obviously suicidality is a completely different thing that needs to be addressed rather than accidental overdose from recreational use or trying to get high. The patients that are suicidal definitely need to be transported. I still, if it's not within your discipline and training, would not try to force these patients. But they're a very different patient than patients who accidentally overdose from recreational use. And as always with any mental health or substance abuse patient, encourage, support, and listen. That goes a long way. I have the luxury and the privilege of treating patients both acutely in the emergency department from overdose, but also seeing these patients in the Be Well Texas clinic when they follow up. And I can assure you they absolutely remember how they were treated when they were reversed the last time, whether or not they were stigmatized, whether or not they were made fun of. They do remember these events and they bring them up very frequently, either in therapy or when we meet them for the first time. And when they feel like the people who rescued them are actually invested in and motivated to get them help, they look at sobriety and they look at recovery and they look at substance abuse treatment help a lot more positively. But that's it as far as my presentation. You should have plenty of time for questions.
Thanks so much, Joseph. Appreciate that. And we actually already have one in the chat already. Holly, I wouldn't mind if you, would you mind unmuting and sharing your question? You might need to educate me on what MI is here too.
So my question was, I've had interactions with an anesthesiologist before who mentioned that naloxone might have some myocardial infarction side effects to it. I know that's not the same as cardiac arrest, but they were pushing back for that being a side effect of naloxone. And the only research that I've been able to find of that happening was when they were using fentanyl as an anesthetic and as an anesthetic and analgesic, and then trying to bring them back with high doses of naloxone. Do we have any kind of rationale or ways to talk about that with doctors who have this idea in their head that
Lost you there at the end.
But I think we got the gist of it. Yeah, Joseph, any thoughts, or we'll open it up to the full group too.
Definitely. So I think naloxone erroneously gets blamed for a lot of things. We know very definitively that naloxone is an opiate antagonist. A lot of what we see as far as side effects in the field, the operating room and the anesthesia suite is a different story, but in the field, I honestly attribute to polysubstance use, and I'll touch on that some with my case that we'll discuss after this. But my argument to that anesthesiologist is that we can adequately treat a myocardial infarction or a heart attack. We have the ability to stent patients. We have the ability to start them on heparin. What we do not have the ability to fix is cardiac arrest from overdose of opiates without naloxone. So it's kind of assuming that there's some truth to that statement. I personally don't think that there is, but assuming that there's some truth to that statement, that it could potentially cause cardiac arrest or cause cardiac stress, we can treat that. We can treat that very effectively. But again, without naloxone, we cannot effectively treat opiate overdose, and that is fatal. What do you have, Dr. Montes? You're muted.
All right, so we know that if we treat patients with Narcan, wake them up from their overdose, and they stay home, that they don't die. We know this because we've done study after study looking at mortality after Narcan reversal. We also know that people use Narcan all the time and they don't call 911, right? And that harm reduction technique tells us that this is safe and effective and good medicine. And the setting of this discussion is totally different. They're talking about using fentanyl in high doses in the operating room for anesthesia. We're using cut heroin in an outside environment, much lower doses, and I'm not going to buy it. Sorry. Narcan is safe and effective. The worst thing you can do is put someone in withdrawals.
I could not agree more. In fact, as a testament to that statement, I've been in addiction medicine for 7 years now, and I originally started in Southwest Virginia, rural Southwest Virginia, Northeast Tennessee, in about 2015 when the opiate epidemic was at its peak, and Narcan was very easily available even without a prescription. You could walk up to any pharmacy and get it. There were actually Narcan parties where people would overdose on purpose and then reverse on purpose Narcan back and forth. So Narcan really does have a very good, safe and proven track record.
Great. Holly, great question. Thank you for bringing it. Megan put something over in the chat. Do you ever start these patients on Suboxone in the ER and give a short prescription and info for an ongoing provider?
Absolutely. So physicians will administer buprenorphine pretty regularly in emergency departments, and thankfully that's becoming standard of care. You do not need a DEA X waiver to provide up to 2 days buprenorphine prescription to get patients into dedicated treatment programs. I'll let Dr. Miramontes touch on it, but thankfully San Antonio Fire Department has been pushing the envelope and being pretty cutting edge and doing that in the field now since 2017, 2018. So not even just in the emergency department, but even our EMS and paramedical professionals, they've been doing that from the ambulance for a couple of years now.
Yeah, so we actually do induction, get them stable, And then we navigate them into an outpatient treatment, either at New Seasons or at Be Well, Texas. And it's been incredibly effective. We meet them where they're at, low barrier, in their apartment, on the corner, wherever, get them feeling better, and then navigating them into care. And we're doing harm reduction. It's all about harm reduction. You can't save someone's life if they're dead. So let's make them not dead, not prone to overdose, and let's get them into treatment.
That is great. And I don't think I've ever seen anyone use a Zoom feature to emphasize a point. Thank you, David, for that. Jeremiah, you got a question from you in the chat. You want to unmute and raise it?
It's just a quick thought regarding those anesthesiologists who are kind of stuck on a problem with Narcan. I was wondering if maybe heart issues are more tied to endocarditis than naloxone. Just throwing it out there.
Definitely. And I think in the street, that's absolutely accurate. And also, unfortunately, I've never met somebody who struggled with a drug problem who also took their personal health very, very importantly and very seriously. So invariably, there's a lot of comorbidities, heart failure, diabetes, hypertension, stroke, heart attack. So there's a lot of reasons to have cardiac stress.
Right. And some of those related kind of illnesses that come from unsafe usage and, non-sterile needles and stuff circle back to those harm reduction principles to help reduce those problems.
Definitely.
Thanks.
Great point. Any other questions on these didactics? Yeah, Christopher.
Hi, how you doing? Chris Velasquez, San Antonio Fire EMS.
Good to meet you.
Can you hear me?
Yes.
So I'm the program manager for San Antonio Fire Department's mobile integrated healthcare program. So I manage the MAT program and the Suboxone program for San Antonio. And it's just a thought. We have trouble engaging these folks on multiple levels. And the mean age, well, for my population, my demographic is about 30 to 35 years old for opioid overdose. I think we need to figure out a better way to engage these people. They're a younger generation. I'm seeing younger and younger, actually, 20s, early 20s, mid 20s. And what I mean by that is I think we need to shift our campaign for reach to Snapchat, TikTok. And I don't know how we do that or what that looks like, but that's where and again, I don't know what that access looks like. I mean, I'm not saying place ads out there and everything, but I don't know how we engage a younger generation through means that they're using every single day, as opposed to making an appointment, driving out there, meeting them. You know what I mean? I just think engagement, we got to get more creative. We got to get more innovative, and we got to engage them on their terms. And that's one of the difficulties that I see out there daily.
That's a great point. And I think, Joseph, if you have a response, I'd love to hear it, but anyone else on the call too, ways of engaging a wider and younger community.
I couldn't agree more. And especially from some of my younger patients, they're pretty candid about the fact that a lot of the ways that they acquire their substances is Snapchat, because the chat feature disappears, or even on Instagram and direct messenger, even sometimes Twitter, believe it or not. There's a lot of vernacular and there's a lot of code switching that goes on these apps. And I'm 33 years old, but I recognize that I have passed the point where there's a lot of language used that I don't fully understand, as far as trying to communicate where substances are available and who to get them from. But I couldn't agree more. I think meeting patients where they are and using the language that they're comfortable with, using the verbiage that they're comfortable with, and the platforms that they're comfortable with is exactly what we need to be doing.
Terrific conversation. Thanks again for the didactics. I think there's lots of questions around naloxone use, and keep them coming because it'll be relevant for the case presentation in just a few minutes. Let's go on and move to some announcements from the Be Well Texas program. Carly, if you wouldn't mind sharing those slides. So Be Well Texas is a welcoming environment with caring professionals who are here to help people start or continue their journey towards recovery. It's committed to expanding equitable access to compassionate, evidence-based treatment and care for substance use disorder throughout Texas. Next slide. The Be Well Texas Clinic provides high-quality treatment for addiction recovery and mental well-being, including offering insurance, self-pay, and no-pay options. And for more information on all of the services available, just go to bewelltexasclinic.org. We'll throw that link over in the chat in just a minute. Next slide. So if you'd like technical assistance beyond what you're receiving in these ECHO sessions, please do complete an online request form, and the Be Well team will be happy to give you individual guidance and assist you. Next slide. And I hope you all join us in November. I can't believe it's almost November already. The next Public Safety ECHO will discuss effective communication in community correction settings. So we'll see you November 10th. All right, I think that's all of those. Yep, they are. Okay, so next we'll get on to the case presentation, and we're back to you, Joseph. As soon as Carly's screen shares that case form, tell us a little bit more about this situation.
Definitely.
Maybe just a minute. All right, tell us more.
All righty. Are we up? Can we go up to the top of the form? Oh, perfect. Okay. So I was working in the emergency department with some of the residents over in the Department of Emergency Medicine. I'm an attending there and supervise them. We had a 21-year-old male who was brought in by ambulance transport San Antonio Fire Department to a large tertiary care center. So the biggest and best hospital, arguably, that we have available, secondary to concern for overdose. The patient arrived as a level 3 medical transport, which means kind of the lowest level of medical transport. He was awake, alert, and talking. They were unloading the patient, and in the ambulance bay, the patient became much more somnolent and sleepy, started breathing much more slowly and more deeply. As the paramedics were wheeling the patient down the hall towards our department, started to need assistance with their airway, and they did a head tilt chin lift. They were bagging the patient appropriately, doing everything wonderfully. Patient arrived in our resuscitation bay, and we gave, I believe, 4 milligrams of naloxone. And the patient started talking again, started breathing deeply, vomited, got nauseated, which is very, very typical and to be expected with naloxone overdose, which is one of the reasons why in that video we ask for patients to be turned on their side, just because nausea and vomiting is so common. Started talking to the patient. He was a 21-year-old male. He was a college student. I will be entirely transparent and candid because I'm human. He was a patient that a lot of us unfortunately get very frustrated with. He was very angry. He was very annoyed. He was difficult to get history from, cursed at me a couple times. Nah, man, I'm fine. I just want to go home. I'm fine. Well, what were you using today? Just some Xannies, man. Just some Xannies. That's it. Maybe some alcohol. That's it. Nothing else. So, all right, well, I understand, but, I really want to make sure we take good care of you when we do a good thorough workup. Really became quite a challenge with my staff, picking fights with the nurses, very much wanting to leave, but then got sleepy again. So I gave him another 2 milligrams of Narcan. He did not respond. I gave him another 4. He did come back. He did come to. I said, all right, you've actually passed out essentially twice now in our facility. Something else is going on. This isn't just Xanax. 1, because you responded to naloxone. Naloxone does not reverse Xanax. And 2, you've required a pretty large dose. At this point, he's actually breathing a little bit more heavily. He is working to breathe a little bit more. He's actually a little tachycardic, which is not what we would expect with opiate overdose. And his blood pressure is very elevated. So he gets kind of frustrated. He's like, well, I don't know. I got my Xannies from a new person. Maybe it was something else. yada, 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 kind of dancing around. It was like, okay, well, so maybe I was using a little bit of cocaine also. At that point, he started to get somnolent a third time, sleepy a third time. So I actually started him on a naloxone drip, which is where somebody has such a high requirement for naloxone. We have to put a lot of it in a bag and then drip it over time in just like an IV, just like IV fluids. He came to again. We put him on a machine to help him breathe a little bit more called BiPAP, and he got much better. At that point, his girlfriend had actually arrived on scene, which was rather fortuitous timing for him, because he really started to get somnolent and sleepy despite being on the naloxone drip, so getting very, very high doses of naloxone. And we were able to get a little bit more history from the girlfriend, because she was very, very concerned. And she was like, no, I was actually with him. He was doing a lot of cocaine. The Xanax came from somebody new. I don't know who, but normally he uses just regular Xanax and alcohol and cocaine. He really doesn't do opiates at all. At that point, the patient actually got so sleepy and had such high increased work of breathing that we had to turn the Narcan drip up even more and ultimately prepare him for intubation. So it was a very complex and very complicated medical picture. And quite honestly, very much a stressful one. But we were able to stabilize him successfully and get him intubated. Can we go on to the next slide? So ultimately, this patient ended up developing something called SCAPE, which is sympathetic crashing acute pulmonary edema. Definitely don't need to get hung up on that. It's a medical term for an illness associated with too much upper. You essentially have completely unblocked upper. So this patient overdosed on polysubstances, Xanax that honestly was probably fentanyl, which is why he responded to high doses of the naloxone, because it was an opiate overdose and it probably wasn't any benzodiazepine whatsoever. It's probably just fake fentanyl in addition to the alcohol and in addition to the cocaine. So we administered naloxone. He got better. We kicked the fentanyl off of the receptors for a time, but then the fentanyl came back. But as we administered more and more and more naloxone, we actually completely blocked all of his downer and completely allowed the upper, i.e. the cocaine, to take over, and we put him into heart failure. This is not to say that you need to worry about in the field putting these patients into heart failure, because a small dose of naloxone from 0.4 to 2 is not going to do this, especially over 1 or 2 doses. I was giving him 3, 4, 5 doses. But what I ended up doing is I unmasked his cocaine overdose. And this is exactly what I wanted to talk about, the dangers of polysubstance use and the fact that a lot of street drugs are not what people think they are. Unfortunately, street Xanax or street alprazolam has become almost ubiquitous with fentanyl. At the very least, it's cut, and dealers will buy pill presses, as I'm sure many of you are familiar with, and press out Xanax bars that are actually just pure fentanyl. But EMS and fire got to this patient first. They absolutely did the right thing and administered naloxone and got this patient back. We administered more naloxone and were able to get him awake enough to give us some history. The patient's girlfriend got there in time and was able to tell us that he did not just a little bit of cocaine, but a lot of cocaine, so much so that when we gave him naloxone, that we essentially let the cocaine be completely unregulated, because there was no downers anymore. There was no fentanyl. There was no alcohol. And he ended up going into heart failure because of the massive amount of cocaine. But we got him intubated. He did very well because he was young, thankfully. He did survive to discharge from the hospital. He was referred to Be Well, Texas, as well as other outpatient services. Unfortunately, he did not follow up. But this was a very good case to kind of demonstrate how naloxone works, the fact that it does work, but also the very real reality that exists for our pre-hospital folks. and our paraprofessional folks that work outside of the emergency department, and the complexities of polysubstance use, which is much more common than monosubstance abuse. It's rare to encounter just heroin overdose. It's rare to encounter just alcohol overdose. The vast majority of our patients now are really polysubstance abuse and polysubstance overdose.
It's a great presentation. Thank you, Joseph. Carly, if you don't mind kind of going back up to the top of those, I want to kind of land back on the questions for the learning community today. Joseph, if you don't mind sort of reiterating those. Carly, could you share page 1? Thank you.
Definitely. So what is polysubstance use or polysubstance abuse? That is anytime you're using more than one substance. Street drugs nowadays, and the people who deal will be very candid. There's a push in the streets to kind of try and find the perfect mix that gets patients high without killing them, but also is highly addictive. And that's one of the challenges that we're dealing with on the opposite end, on the healthcare aspect and on the law enforcement aspect, is trying to take care of these patients. And they're becoming more and more complex and more challenging to try and identify what the substance was and what's going on. But quite literally, a lot of people, the vast majority of people, I would even argue, who are overdosing now are overdosing on a little bit of this, a little bit of that. And with how cheap and how little fentanyl it takes to cause overdose, that's becoming much more of a regular problem. Naloxone, of course, like we touched on in the presentation, is a opiate antagonist or an opiate blocker. It is effective in mixed overdose pictures, which is what this case is intended to demonstrate. So even if you get a patient that you know there's multiple different things on board, you're never wrong for administering naloxone, and very often you are right for administering naloxone, and you can get benefit even if they also are taking benzos and also are taking cocaine and also are taking alcohol or whatever. What is the most important thing to do in an overdose of any kind? As we touched on during the previous presentation, BLS principles. If you don't have naloxone, that's okay. CPR saves lives. If you give naloxone and it doesn't work, that's okay. CPR saves lives. If you give naloxone and it does work, but then you don't have any more and they get sleepy again, that's okay. CPR saves lives. So in the end, no matter what, CPR is going to be the bedrock and the foundation of saving lives for patients who are either apneic or bradypneic. If you don't have naloxone, or you do and it doesn't work, or you do and it works, but then you need more and you don't have enough. So ultimately, you still always have the tools to save the lives of these patients that overdose, and that's basic BLS and CPR.
Great, thank you. I appreciate that. That kind of circles us back to the didactic. Thanks, Carly, for pulling that up. You can stop the screen share. Well, let's open up the room to questions for Joseph about this case. And I just want to kind of openly acknowledge there are multiple disciplines, multiple professions represented in this audience, and questions from every sector are welcome. I think that's one of the kind of cool things we can do with this series is look at this case, which I think is presented as a kind of a more medical perspective, and look at it from various other lenses as well. So opening it up to the group, any questions for Joseph about this case?
Hi, I actually had another question. So could it have potentially, I guess 2 questions in this. So you mentioned CPR being very, very helpful in these situations where there could be also cardiac events happening. How does that work when fentanyl is involved and could cause this like wooden chest syndrome?
That is a very good question. So background, wooden chest syndrome is associated predominantly with fentanyl only because it's a synthetic opiate. Heroin doesn't do it. Hydrocodone really doesn't do it. Hydromorphone, Dilaudid, morphine, these really don't cause wooden chest syndrome. There's a serotonergic component, and there's also a component that's unknown as to why this happens. But fentanyl, and it is not dose related. There are case reports of very low dose as well as it happening with very high dose. where you get essentially a muscular spasm of the chest wall muscles and the diaphragm, making it very, very difficult to ventilate these patients, or very, very difficult to help these patients breathe. In that situation, the treatment is naloxone. But in that situation, honestly, the best treatment is doing the best you can. You can still do CPR effectively, even if the muscles of the chest are in spasm. It will not be as effective, but you can still get chest wall movement. You can still get ventilation, and you can still get compressions on the heart. As I'm sure you know, Holly, the recommendations for public non-advanced or non-medical CPR are chest compressions only. It has circled back around, and it's no longer airway breathing circulation. It's now circulation airway breathing. So when in doubt, chest compressions on their own are effective. Is it better with an airway? Absolutely. Is it better with rescue breathing and with oxygen? Absolutely. But chest compressions on their own, even in the setting of wooden chest, would still be better than nothing and would still be effective.
Thank you. And the second part of my question was actually, were you guys able to do a tox screen to see that it actually was partially cocaine, or could this have been a case where carfentanil may have been mixed in that has cardiac effects?
So you're talking about the 21-year-old gentleman. He was positive for cocaine. His girlfriend actually showed me a picture of the supply he was working with, and it was quite a bit of cocaine. He later, when he woke up in the ICU, had a for lack of a better description, proverbial come to Jesus moment with the intensivist, and admitted to doing like 5 or 6 lines of cocaine prior to coming after taking the Xanax pills. Which clinically fit his presentation of initially having the downers and the respiratory depression, and then subsequently the large burst of cocaine, the tachycardia, the high blood pressure, and the heart failure.
Okay, thank you.
Mm-hmm.
Great question, Holly. Thank you. And I think it answers what you described. Polysubstance use is happening a lot more than often. So I think there's curiosity about kind of what that looks like. So thanks for the clarification, Joseph. Other questions?
I have a question.
Definitely.
Which is on the role of alcohol in the process and in your response, and how it can affect sleepiness and other forms of biological depression.
Definitely. So alcohol is a very complicated drug. We could have an hour-long session just on alcohol and all the receptors that it hits. From a pharmacology perspective, alcohol is described as "quote unquote" a very dirty drug. And by that, what I mean is that it hits lots of receptors. It's not very focused. It hits GABA, it hits acetylcholine, it hits norepinephrine, it hits dopamine, it hits a lot of different receptors. And the clinical picture associated with alcohol on its own is called paradoxical disinhibition, which is kind of difficult to embody or difficult to envision, but it's essentially that aspect of where you get kind of this relaxed, placid feeling, but also simultaneously get this energy to go out and party and enjoy yourself and do things. Paradoxical disinhibition. So you feel more relaxed, you feel more less anxious, but conversely, you also have this energy to go out and do things. But alcohol, especially in a mixed picture, just does a lot of stuff, to be entirely honest with you. It is synergistic with benzodiazepines, meaning synergy. The best way to think about it is 1 + 1 does not equal 2. 1 + 1 = 3 or 4. So if you take a shot of alcohol and take benzos, it is much stronger than either one on their own, and much stronger than simply 1 + 1 = 2. But alcohol is also synergistic with opiates as well.
Thanks.
Thanks, Joseph. David, you raised a question in chat around what xylazine is.
Xylazine is kind of a new and upcoming thing. And I saw actually the big informational poster / pamphlet that came out with San Antonio Fire Department. But it's a synthetic drug that if I remember correctly, comes from an opiate base, but it causes pretty dramatic vasoconstriction locally, to the point where it can cause skin necrosis and skin sloughing and essentially cause musculature and skin to die in the area that it's injected. But my understanding is it's an adulterant that's meant to augment and kind of be synergistic and create a more potent and more strong high, at the cost, unfortunately, of pretty severe, pretty gruesome tissue damage.
Great, thank you. Good question.
Mhm.
Other questions for Joseph?
I have a question, Dr. Martin. We, from my past, we worked a lot with polysubstance abusers, mostly with heroin and heroin users at that time, and alcohol. And we were using, this was back in the 90s and 2000s, we were using naltrexone hydrochloride, which was a long-lasting, the long-lasting part of the naloxone. And it seems like Suboxone has become more of a popular use rather than the naltrexone. Is that still not an effective way of helping individuals to kind of keep away from using the opiates and maybe even the fentanyl if it's being popped into the streets and they're trying to stay clean and sober and drug-free and sober? What are your thoughts about that?
That is a great question. So I'm a big fan of naltrexone and I'm a big fan of buprenorphine. Unfortunately, they are mutually exclusive based on how they work. Naltrexone, you're exactly right, is a long acting version of naloxone. It's a long acting blocker. It's incredibly effective if you have a patient who's willing to use naltrexone, either depot where they get the shot for 3 weeks to a month, or the pill version where they take a 50 milligram pill every day. It will work effectively to block the effects of any opiates that are administered. Quite effectively. In fact, you can overcome naltrexone, but it requires incredibly large doses of fentanyl or other very, very potent opiates. The reason that buprenorphine ultimately supplanted naltrexone for treatment in heroin and opiates, unfortunately, is that compliance is a big issue. If you give somebody who is used to taking heroin naltrexone too soon, you'll put them into withdrawal because it's a long-acting form of naloxone. But even after the subacute phase, even after 2 to 3 to 4 days, most patients that have a long-term history of opiate use are very uncomfortable on naltrexone. They're itchy. They have kind of this low-grade general malaise, flu-like, a little bit of nausea, a little bit of vomiting, a little bit of diarrhea syndrome for a couple of weeks. And it's just the fact that their receptors are slowly switching back to being out of a heroin, out of an opiate-rich environment into a pure opiate-blocked environment. So compliance is a huge, huge issue. You have to have very motivated patients. I do have some patients that are on naltrexone that are both have a history of opiate abuse and alcohol abuse, but they're incredibly motivated and they're very much in the minority as far as patients go. I would say less than 7 to 5%, because they very much have to be in a very good support system, in a very, very safe place, good roof over their head, very consistent, very structured, just because it's so challenging to get patients to be willing to deal with that subacute withdrawal syndrome that they get. But to answer your question and to the practice that you guys were engaging in, absolutely effective, very, very good. The hard part now is salesmanship, and for lack of a better word, and getting patients to be willing to do that.
I'm happy to hear that because it really worked real well in the community supervision in the corrections. And so I was very successful. We had really good success with the veterans that were under supervision and some of our older veteran, drug users. So thank you very much.
Of course, is very good medicine, and it still is. I think the challenge is that nowadays, if you say, I can give you this medicine that's going to make you feel really crappy for 2 to 3 weeks, but you'll be protected from overdose and be protected from using it after that 2 to 3 weeks. You'll feel much better. Or I can give you this medicine where you'll feel great almost instantly and you'll be protected. It's harder to sell. But again, it definitely is still being used for the patients who are particularly motivated.
Good question. Thank you. And Adrian, thanks for sharing. If you're interested in learning more about xylazine, the recent harm reduction echo touched on that. You can watch that video in just a bit once it's available. We don't have a lot of time, but I kind of want to pivot here. Joseph,
Before we do, Andrew, I'm
yeah,
sorry, could I just chime in really fast? I was hoping Dr. Martin could say a bit about the overdose risk with the naltrexone non-compliance, because I know we have a lot of community corrections folks in this learning community. And for a number of years, the manufacturers went all around the country and spoke to community corrections and kind of neglected to emphasize the overdose risk with the non-compliance. So if you wouldn't mind just saying a bit about that.
Definitely. So we all know, predominantly men, but there are some women out there too, but we all know those people who take a lot of pride in being able to drink a lot. People who have struggled historically with heroin or opiate use tend to develop a similar memory of, oh man, back in my day, I could use 1.5 grams and I'd be fine. I could use 3 grams and I'd be fine. The problem is tolerance wanes very quickly for opiates over time. So if you are using naltrexone regularly, say for 3, 6, 8 weeks, but then stop and then subsequently go back to using, your risk of overdose is incredibly high because invariably your eyes are bigger than your stomach, so to speak. Your memory of how much you could use in the past is a disservice to you. And these patients will go out with the intention of recreational use and use what they previously used to use, except their tolerance is gone, and then overdose inadvertently.
Oh, great question. Thank you, Adrian, for bringing that. We don't have a lot of time left, but Joseph, I wanted to ask you this. You described EMS and fire, got to this patient first, and you said they did the exact right thing. And then you had the experience, and then the patient was discharged, and then there was no follow-up. I'm just curious, as we look beyond your experience, what would you have liked to seen? How can the other professions who are part of the care for this patient, what strategies can they use if they're the next step for this patient?
That is the greatest philosophical question of our time. Everybody on this call knows that even in a perfect world, 50% catchment rate for these patients is fantastic. It's just so hard. And part of the pathology of addiction is quintessentially, yeah, it can happen, but it's not going to happen to me. And especially for younger patients, increasing catchment of those patients and getting them into treatment and services is combating that pathology of, yeah, it can happen, but it won't happen to me. I very, very frequently, when I'm teaching about treating addiction medicine patients, we'll make the comparison that all of our patients, regardless of age, are essentially like 16-year-old boys. They have impulse control problems. They have inability to measure risk and reward benefit appropriately. And every single one of them, unfortunately, struggles with the mindset of, quote unquote, yeah, I know it can happen. It happened to 6 of my closest friends, but it's not going to happen to me. And combating that mindset is incredibly challenging, and I don't have a great answer for it. Some people have argued that using celebrities and or using people who have been in treatment successfully to make treatment look sexy and cool is the thing to work. I think for some patients that works. Some people have argued taking a paternalistic approach works. I think for some patients that works. And some people have argued the judicial system and it being forced without much choice is the way to go. And I think that works for some patients. I think just like diabetes and hypertension, the fact that no one size treatment fits all, I think the thing is we have to be flexible. We have to be good at understanding and reading our patients' needs and wants and what motivates them, what demotivates them, and then bringing the tailored approach to them that they need. The hardest part out of all of this is all of that requires time. The emergency department time is a huge luxury. As someone who works in both spaces, It is not uncommon for me to have 6.5, 7, maybe 8 minutes to see and take care of a patient before I've got to see the next one. And so getting into that level of understanding someone's psychology and again, what motivates and what demotivates them is challenging to say the least. But I think the short answer to that question is tailoring the approach to what works for that patient after you've had the opportunity to assess their psychology and what they're responsive to.
It's a great answer. And I think it reiterates a lot of what we've been hearing today is that no one treatment works for every single patient. And I think zooming out even more, no one discipline is going to solve this issue on its own. And so I hear a case that's about a lot of cross-disciplinary collaboration and partnership.
Absolutely.
Well, thanks again, everyone, for joining. Jeremiah, as our lead today, you have the task of summarizing some of the key points from our conversation.
Cool. I will try to do those rapidly since we're at the top of the hour. Well, first of all, Dr. Martin, thanks for spending all this time with us today. I really appreciate what you've brought to bear here. As you're pointing out, there's polysubstance has been it's not a new thing. It's been a core to the overdose crisis for a long time, generally to drug use for a long time. It's just that it's gotten some more kind of attention these days. But how it presents in the issue of fentanyl being in the drug supply. And so the specific interesting challenge of the particular case, but this is coming up with how Narcan can prevent the overdose from an opioid overdose in the immediate moments. You've kept someone alive, but now it's unmasked a different problem, being the overamping from the stimulants, and what will that be? How to address that and keep the person healthy and alive to discharge, and then given the half-life of Narcan itself, how we need to keep giving it, and then there are other depressant issues from other drugs or alcohol. So it's a challenge for your people in emergency medical services. Let's see, running through my notes here. CPR saves lives. Say that again. CPR saves lives. This is key. It's a big point that we point out again and again in our SHIELD training that is part of what I do in my job. Where there was commentary on wooden chest syndrome regarding fentanyl, and just folks trying to do their best to address it. Alcohol, lots of different effects, and how importantly it's synergistic for benzos and opioids. Discussion of the continuum of care. We were focusing there on naltrexone and buprenorphine, Suboxone, didn't mention methadone. But then that links to the important issue here. We're talking about patient-centered services and impulse control. Since the impulse control issues itself is part of the disease of addiction, how to address that and get people connected in this. We've raised the issue of patient-centered services, and we've been touching on harm reduction throughout. I know one thing we didn't talk about was peer navigators and other folks who can help connect people humanly. Because, Dr. Martin, at the very beginning, mentioned how important it was to have a good, respectful treatment of the people, of the patients. And since people are coming to this with such often, particularly people with substance use disorder, will have had so many bad experiences. As someone I work with calls it system underperformance disorder. They've been getting so much bad treatment from people over time that trying to connect people with through peer, coaches, people who can really, and a lot of people in harm reduction, people with who themselves have lived experience, maybe that will help. I guess I'm throwing in commentary here that wasn't actually discussed, but it seems like a way that we'll want to probably talk about down the line, particularly since, as mentioned, the folks working in the emergency department don't have time to go into all those things. They're just trying to keep people alive. So thank you, Dr. Martin, for keeping people alive, for what you do. I know addiction medicine is a wildly understaffed world. It's a sort of a new frontier. A lot of doctors are nervous about getting into it. So thank you for what you do, and thank you all for discussing for this great discussion today, and I'll pass the mic back for closing.
Great, thank you. Great wrap up, and I'll just repeat the thanks, and Joseph, you're getting a lot of that in the chat too. Thank you all for joining us today and for sharing your questions and your thoughts in the conversation. We hope to see you in about a month's time at the November 10th session. Again, thanks to our hub. Joseph, thanks to you for bringing the case and the didactics, and especially thanks to everyone who shows up to make these sessions what they are. Have a good Thursday. We'll see you soon.